Welcome to the Caregivers podcast. I'm your host, Dr. Mark Ropaleski. You can call me Dr. Mark. Today's guest is Dr. Laura Katz, a clinical and health psychologist who sits at the crossroads of chronic GI pain, pelvic pain, endometriosis, and the nervous system. She works with people whose pain has been dismissed, misunderstood, or even minimized. She works with caregivers who are exhausted, not knowing where to turn. And she works with clinicians who feel trapped inside a system that wasn't really designed for the level of suffering they're seeing in their patients. Chronic pain is no longer a niche issue. It's affecting young people, parents, partners, students, and caregivers everywhere. And Laura's on the front lines of helping people rewire the way the brain processes pain, especially when standard care runs out of answers. Welcome to today's episode. Welcome back to the Caregivers podcast. I'm your host, Dr. Mark Ropaleski. You can call me Dr. Mark. We're here today for yet another episode. We're grateful to be here, and we're grateful that you're here. And most thankfully, we're grateful for our guest, Dr. Laura Katz, who's joining us today, a clinical and health psychologist with broad expertise, and you won't want to miss this episode. So let's jump in. Laura, welcome. So happy you're here.
Happy to be here. Thanks for having me.
Great. Well, you're with people who suffer in pain every day, and it's hard pain and it's frightening pain. What was the moment that you sort of realized that there's something deeply wrong about how we deal and respond to chronic pain?
I think that's such an interesting question because there's so many different moments along the way, and I continue to have those moments almost every single day that I'm in practice. And I think it's just the fact that there's so many disjointed systems and parts and pieces. And that's really part of the big struggle of what, both healthcare practitioners and patients themselves are really having a hard time with, is in fact putting all those pieces together. And so I can remember moments everywhere from training to when I started working in hospital systems to private practice and trying to, put all the teams together and pieces. And there's so many different moments, and that continues every day.
It's interesting that you allude back to training. I remember when you were doing your PhD and we were all working together in the clinic and seeing patients, and there was just a whole broad dynamic interplay, and even the teams in the clinics weren't used to the presence of yourself and your colleagues as we were all embarking on these, detailed research projects that really played a role in framing, new approaches. And I'm sure many of which you actually apply in your own practice today. But that's what it took. And, to your point, I think training from the beginning needs to raise awareness of chronic pain in medicine and in patient care across the board, whether it's psychology or medicine or nursing, so that there's a more holistic approach. So what do you think we kind of misunderstand the most about sort of how pain and then obviously mood and fear shape chronic pain behaviors among patients when they're suffering?
I think it goes back to that initial question is that, a lot of times patients will come in to see me or someone else, and they have like 13 different care providers. And so they have someone that they're seeing for, maybe their gynecology condition, and somebody that they're specifically seeing for widespread pain, and somebody for migraines, and somebody for GI. And then they also have all these other, alternative and healthcare practitioners. And the reality is when you start to see it as one underlying condition, one person, one body, one nervous system, all of the pieces and all of the symptoms really start to come together and make sense. And that's when you start to notice big improvements and changes for a lot of these folks who tend to be labeled as treatment resistant.
So obviously integration of the whole patient in front of you, which is such a, huge element in keeping it patient-centered. But obviously, we see a lot of, as you say, this sort of disjointed approach, which results in some element of mishandling of the whole person in front of you. And that obviously carries a huge burden on the patient. What's your feeling for when you have patients coming to meet you for the first time? What's their experience been like?
The experience is incredibly challenging. And so, I work with a lot of individuals who have conditions like endometriosis or a lot of gastrointestinal symptoms. And many of these individuals have not necessarily received appropriate diagnosis, assessment, treatment for anywhere for up to a decade. So by the time that they're finally starting to get somewhere, they've experienced so much medical trauma, from being, dismissed by various providers, being sent home and saying it's just menstruation, or maybe you need to change your diet. Have you tried losing weight? And so, what it leads to is somebody who doesn't really trust their body, somebody who doesn't trust the system, and is feeling really helpless and hopeless about their whole situation and doesn't know what to do next.
And obviously that carries some burden forward onto individuals involved in relationships with those patients, whether they be their caregivers or whether they be their partners. And I would even imagine even some professionals might approach you and say, how do I deal with these chronic problems? I never learned how. I want to do better. I mean, it seems like there's a burden that's kind of spread around numerous areas. So above and beyond the patient burden, which especially with that lead-in period until someone approaches their symptoms and their condition with a more integrative approach, which is, your area of specialty, what do the caregivers and even some clinicians experience? Like what have been your encounters with them? And can you shed some light on that?
Yeah, I think it's incredibly challenging for the caregivers and the clinicians as well, because, as we know, chronic pain gets so few hours in medical training. And then because of our siloed approach in healthcare system, we tend to, just refer. And there is no holistic, care plan or treatment pathway for a lot of these patients. And so, I find with a lot of the clinicians and physicians that I work with, they really do want to help. They just may not know how or where or what, particularly when, you have 70 people on your clinic list that day and, you're trying to put out a million fires. It's really challenging to fit it all in, and how you integrate all of that within your practice can be really, really hard.
Well, the mere fact that, a lot of these require frequent follow-up and sort of building confidence in stages, both in the patient-practitioner relationship, but also in the patient's relationship with themselves, and frequent check-ins. And as you say, the system's not designed for that, nor are time allotments historically available for that sort of holistic approach, which takes time. It's not a prescribed 10-minute visit in a busy, packed list. Unless you've known the patient perhaps for years and years and you've already gotten some headway in the process where then you can have little touch points. So what about, have you experienced that caregivers sometimes during the encounter appear very distressed as well?
Yes, I think sometimes caregivers may be distressed. I don't know if they always appear distressed. And that's part of, the persona of, being the team lead or the medical director, and not knowing what to do or where to go, not having a team to rely on, particularly if you're a sole practitioner in the community or something like that. And maybe it comes across as being dismissive. A lot of the patients that I've worked with maybe have been discharged from physicians prematurely or, just said, I can't help you. I don't know what to do. So what do I do next kind of thing? And so it creates a little bit of a jump between, different providers, different systems. And, if you were the next physician or clinician, getting this referral, you're walking into a patient interaction where the patient's already upset, invalidated, dismissed, has a decade of medical trauma. And then before you even open up your mouth or look at their chart, this is what you're walking into. And so I have incredible amounts of empathy for, clinicians who are working within these kinds of populations because the system doesn't support and training doesn't necessarily support what to do next.
No, absolutely. And I'm sure it has an impact on non-professional caregivers, the patient's partners and their loved ones as well. Do you have your patients attend sessions with you alone, or do they often come with their partner?
So in my particular practice, I do see patients alone, but in other places that I've worked, we've often had sessions or different appointments that partners can come in, because a lot of times it's really hard to understand what it's like to experience a chronic pain condition that you can't see, that you can't, visualize, that you can't experience because you don't live in that person's body and what that might be like.
Mm-hmm.
And so a lot of times there's some really good videos like Lorimer Mosley, Tame the Beast, that we can give to patients to view with their partners and have them come along to follow-up conversations, because it's a really unique experience. It's not just, acute pain. Everyone has had an injury, but then as that persists and becomes widespread, very few people will actually know the true impact and how that actually affects your quality of life until you're in that body and in those roles that have been impacted and influenced.
So, in your role as a health psychologist, are we actually seeing a surge in chronic pain in the population, or are we kind of scraping that surface where we're getting better at recognizing its existence and finally acknowledging it in a different way? Or is there more of it around? Is it more prevalent?
That's such an interesting and complex question. It's probably similar to the whole notion of, are rates of autism higher because we're better at assessing and diagnose, or we're more sensitive? And it's so nuanced.
Mm-hmm.
I think that we do have better systems for detecting, seeing, investigating, understanding chronic pain. It is becoming more accepted, and I think it's less taboo. So patients are
Absolutely.
feeling more comfortable coming in and talking with their docs and going to clinics and appointments. I think why we might be seeing higher incidence rates also is there's so many different reasons for a variety of systemic issues, but there's so much distress in our society today. So the rates of things like anxiety and depression are just skyrocketing across all echelons of society and our population. And because of that, when your nervous system becomes so sensitized to emotional distress, it's not surprising that acute pain becomes chronic in a lot of different areas.
Well, we certainly see that in GI, and we talk often about the brain-gut axis, but in reading your work and being more aware of all of the different elements that can be affected, it's really the brain-body axis. And I'd hope we can explore that a little bit further. In a previous interview, you spoke about, I think back to when my kids were little and how intrigued they were with dinosaurs, but you spoke about the Velociraptor brain. Which was sort of this sort of hypervigilance signaling system, but yet, it may be primordial, but it may not be the solution for how we need to think about pain in 2025. So could you expand on that? And I think I always like to review it, but I'm sure our listeners also would really like to have a good understanding of where we're seeing this difference between, the acute injury and then when chronic pain sets in. And as you know, it doesn't have to always be triggered by an acute injury, just like chronic pelvic pain is not an acute injury necessarily triggering it, nor are migraines or other forms of pain. But can we explore a little bit for the audience, like the framework that you operate in when you think about pain and its chronicity and how our body reacts to it?
Mm-hmm. I always like to take that comprehensive approach. And so, we were talking about before, patients often come with multiple different symptoms, issues, diagnoses, and problems. And I like to operate under the principle of parsimony. So if we can think of what is the underlying thing that might be responsible for these 3 or 4 different chronic conditions and plethora of symptoms that are happening, that often, makes a lot more sense both for, the treatment approach and team as well as the patient themselves. It's much easier to treat 1 or 2 things than to feel so utterly overwhelmed and helpless about the 30 things that they feel like they have to control and be on top of. And so, with that, I like to take that nervous system approach. And, I talk about the same things when I go through psychoeducation, both with patients as I do presentations academically and so on, because it's the same information. And I think it's really important that we don't necessarily talk down to our patients. They are as capable and competent in their ability to understand the neurobiology of the brain, the spinal cord, and all of these pain messengers and signals, and why they're exacerbating and what's happening. Because once they get that, they're much more likely to be able to adopt coping that's effective and adaptive in their everyday lives.
Absolutely. I mean, and it's an interesting conversation. I've even alluded to some experimental models in GI that sort of explain why when you're stressed, pain can feel that much more for the same stimulus, or if you're depressed or if you're anxious or what have you. So what are the two sort of frameworks? I think of a Velociraptor as being this sort of hyper vigilant sort of communication pathway. And is there another pathway that we need to tap into, like a more mellow relative of the Velociraptor, just sort of grazing on herbs in the background, or?
Yeah, absolutely. And I think it goes back to, I love the analogy, and I always use this with my patient, the flipping the lid. And so when we think about our window of tolerance and what we're able to actually handle day to day, when we're in, a pretty regular window of tolerance, we can use our prefrontal cortex. We can think, we can plan, we can organize, we can control our impulses. And that's the state that we really want to be in, because we can tolerate experiencing stress and pain and cope with it relatively in a manageable sense. And this is when we're logical and rational and can think things through. Once that gets overloaded, that system, and our prefrontal cortex goes offline and we start firing and acting from our amygdala, that's when we enter the Velociraptor phase. And I only say that because I have 2 and 5-year-old boys. And so our house sometimes goes from very calm and neat and organized straight into dinosaur mode, right, when everyone's just acting and reacting and it's chaos. And it's really hard because everything in your body starts to go to that fight or flight mode, and you're not able to think, you're not able to plan, and you're not able to cope. And so it's really important for, all of us as both clinicians and patients alike to match our coping to the actual state that our brain and our nervous system is in. So if we're, completely in panic mode, if something's going on in the office, or if our patient is coming into an appointment and they're feeling really traumatized and triggered, trying to get them to be logical and think things through and, talk about things like a plan, it's probably not going to happen. And so it's important to take those moments to match the fact that we need to ground, we need to downregulate and bring our nervous system back to the point where we can use our prefrontal cortex again. And then we're able to do all those things that we want to do.
And that's pretty tough if you have chronic distress from, whether it's psychological mood disorders or even chronic moral distress. I think has been shown to actually inhibit the prefrontal cortex's ability to help regulate the amygdala. So for our listeners, I think of the amygdala as being that core sort of cave person brain that's located deep in the brain, and then the prefrontal cortex sort of up around here sends those signals down that just sort of tell it, whoa, let's think this through a little bit. Let's look at the big picture. Let's modify our reaction to what's going on and see, if we can just take it more calmly. So with that in mind, though, when we think about chronic pain, there must be some myths out there. I mean, I know you're on social media and there's a lot out there that's unfiltered, but are there actually myths regarding chronic pain that are doing more harm than good out there? And, if you had a choice of some of the key ones out there that you could delete off of social media to just sort of get people away from that sort of thinking and back honed into some of the foundational framework that you use in your practice? Like, what would those targets be?
I think social media is such an incredible, but also a very scary and harmful place.
Mm-hmm.
And we've all experienced that on some level. And because of that, you find a lot of people who are very highly educated, overqualified, are at the top of developing these gold standard treatment pathways. And they are not the ones that the general mass public are listening or responding to. And that's the part that's a little bit scary, where you have these influencers on social media who, of course, everyone, I'll give them the benefit of the doubt. They want to connect, they want to support, they don't have ulterior motives. But sometimes, the rhetoric that they're going into can be quite harmful. And so I think a big notion is the fact that there's no one thing that's going to take it all away. There's no one thing that's going to work for every single person. So as soon as somebody online is telling you, you absolutely have to follow this one diet or try this one supplement or do this one exercise, that's when your spidey senses should kick in, and you should acknowledge that, you really got to do your research in terms of, what's the evidence here? Because a lot of things are just floated online without necessarily having much rigorous evidence or research to back it up and behind it.
Yeah, I think it's become obvious, even managing irritable bowel syndrome, for example, and chronic pain in that scenario, is that when patients do improve, it's usually the sum game of 3 or 4 interventions that may help 15%, but you add them all up and then you're in that 60 to 75% benefit range. But if you look at each one in isolation, it's not a massive game changer. But if you're patient enough and you integrate your approach with coaching to be able to amass those small wins, suddenly the landscape changes. And I think we're seeing more and more of that. And to your point, finding the one, whether it's in love or in treatment, is probably not really how it works. So how do you go from there then? Do we need more education, more dedicated online presence to really get the message out? I know you're doing a great job, but is there a sort of, among associations and colleges, international organizations, is there more of a global attempt to sort of get some of the more mainstream thinking about chronic pain disseminated?
I think that is absolutely what needs to be done. And, 10, 20 years ago, we used to hold academics and publishing and papers to such a high regard. And somewhere over the last little while, with social media and its influences, the public isn't looking to that anymore. I would love to see more high quality, skilled clinicians, take just moments and feel more comfortable, talking about what they do and the research and what they're doing online. So having a lot of these academic organizations and committees and, all of these conferences that we go to, doing more presence and having more of a presence on social media just for everyday, regular people and patients alike. I think that would be such a huge component of, having, the dissemination of knowledge that's readily available in pieces that patients can absorb.
I think with that dissemination, you would sort of break that pattern where, there's more of a comfort level among patients and among listeners that, okay, this is starting to make sense. I think I can handle this. Maybe I can find someone to coach me, although, resources, as we'll all attest to, can sometimes be spread out thin. But my biggest worry is that the chronic pain sort of takes over a patient's identity, and because of that vulnerability, and can result in sort of years of sort of feeling invisible and feeling disconnected with yourself. What are some of the impressions you get during your patient encounters when you see that happening? Like, what are you witnessing in the patient who feels like they're floating like an invisible island, and in that sort of self-vulnerability that they have and how it shapes their identity?
It's a really good question. And I think that, it can often be bimodal in the sense that it takes two approaches where a patient might feel totally alone, invalidated, helpless, hopeless. And, their whole network has kind of let them down, the personal, their treatment network, and they don't know where to go and what to do. And there's also this other kind of patient that might come forward that it is a part of every Facebook group and 14 different networks and on every Instagram page. And that's also pretty dangerous because all they're being fed is this identity, and nobody's online if they're living their life and doing well. People are online because they're struggling to cope, they're not getting resources, and they need that connection. And so the approach would be similar, but a little bit different for, those two populations in the sense that you really have to do an evaluation and assessment with the individual in terms of what matters, what's important to them in their life, what do they value, and, what are those characteristics right now, and what ideally would they like them to be? And when you start to do that value analysis, you start to notice that, ideally, what matters to them is their children, their family, maybe their faith, their occupation, some leisure activities, and what are they doing right now? All of those things are ranked almost nothing. And so you really, once you start to notice that discrepancy, you can start to get patients to do some work and take steps towards how do we adapt your day-to-day life and functioning so you're acting in ways that are more consistent with the values that make you and your life and your existence meaningful in your everyday life.
And I guess it becomes empowering if you can get them engaged to sort of set the first little wins and series of milestones towards each of those categories and sort of build that team approach and that listening approach from the outset. Probably something many haven't really experienced before, and it must be refreshing. I think you've certainly done that with your Endometriosis 360 group approach, where you've really integrated a really holistic approach to managing some of these individuals who've been suffering for years with this condition and feeling potentially unheard or feeling incurable or feeling unself-manageable anymore. Can you tell me a little bit about that program that you've built? And obviously it's very successful and it's growing, and I'm really happy to hear that. And what's been the key to the success? And maybe that's a blueprint for numerous other areas to really flourish in the space.
Happy to share, and thank you for those kind words. So a little bit of a backstory on the program. A lot of that work is based on some of the academic work and research I've done in Dr. Dean Tripp's lab there at Queen's. And I was actually hired by the McMaster University Hospital at the DeGroot Pain Clinic to start to actually build that pelvic pain program from the work that we did. And so I along with a great team, developed and ran that program for about 8 years. And then I started to think about what might this program look like if we were to offer it in the community. And so that was the opportunity where I had the privilege of connecting and working with Dr. Matthew Leonardi, and him and myself and some others, such as our registered dietitian, Emily Arthur, and our incredible physiotherapist, Jill Mueller. We all co-founded Endometriosis 360. And I think what makes it so unique and so successful is we're a team. It's an interdisciplinary team, and every single patient interaction is done in collaboration with each other. And so what's really nice about it is most of the time when patients come through, they've had all of these hundreds of appointments with different disciplines and different clinics, and they bounce from appointment to appointment to appointment. And we're the first time they've ever seen 3 of us in that appointment altogether. And we're able to see them as a whole person, talk about these issues from the 3 different dynamics. And we like to call it, I'm the top-down approach. So the psychology, all the cognitive and emotional. Jill is the bottom-up. She does all the somatic, the functioning, the body. And Emily is the inside out. So what is the fuel and all the stuff you're putting in your body and your relationship with food? And when you're able to tackle such important concepts and see a person literally from top down, bottom up, inside out, they finally feel seen. And that's when you're able to help them get unstuck from certain things that they've been struggling with potentially for decades and get them to start working toward goals and starting to see really big improvements in outcomes.
How many sessions does it take for your patient to start feeling that, I've arrived somewhere new, this is a fresh experience, or I actually am starting to feel a little bit empowered?
Session 1. Session one.
I like the sound of that.
And that's just it. Like from all of so the first time we meet the patient, we meet them for an interdisciplinary assessment. And that's to assess, who they are, what's going on, and really to talk about, is group a good fit for them? Is, both from our perspective and their perspective, is now a good time, and work out all of this sort of details. And every single session we have with a patient, it ends with them being quite emotional and tearful about the fact that this is the first time, maybe ever, that they've felt heard and seen and empowered and validated. And it's so motivating for them because they want to do the treatment. They want to make changes because they really feel that all of the pieces are going to start to come together and they're going to be able to get somewhere. So session 1.
Well, it sounds like it's the first time they're meeting up with thoughtful, elegant design in the more holistic care delivery that's required to manage chronic pain. I can only surmise that the spillover in terms of the impact on those patients, partners in life, perhaps parents, the individuals who care for them, or even their friends, there's a big relief that sort of extends from the core, and that everybody around them can suddenly start feeling like they can recontribute. And as we've spoken with Dean Tripp previously, some of the catastrophizing and helplessness that arises in chronic pain can paradoxically alienate those same important people in your life, whereby not only do you feel invisible, but at times you start feeling more alone because those relationships have disintegrated around you. But this sounds like a big turning point to me.
Mm-hmm. It's a big turning point, and it's a potential. And so, we've had sometimes, within our team, like I'll see people before, during, and after for individual sessions, aside from our group. And we get things like patients almost have a little bit of distress because their identity is no longer their chronic pain. And so they almost don't know how to function in their lives or their roles or their relationships. And so it requires some reimagining and re-envisioning about, what do I do next? And if all my time and effort and energy isn't spent, on that identity and appointments, what would I like to do? And so helping people in terms of their relationships, their intimacy, their children, their careers,
Wow.
and then also their treatment teams. So physicians that, after being discharged from our program, they also notice a difference that, they're better able to adhere to treatments. They're much more, on board with some of the options, especially when you're starting to talk about things like central sensitization in interdisciplinary care. So I think all around it helps outcomes for patients.
And I'd love to have you back one day to sort of give the synoptic of, for a physician audience, whether it's in primary care or even focal areas of specialized care, just sort of like the top 10, if you will, steps or approaches to facilitating engagement while not every patient has access to your program, let alone programs across the nation or in North America, because they're not yet fully developed. But certainly you've got a great blueprint there. We could certainly benefit as a community of medical practitioners being updated on this sort of approach to sort of make some early gains along the way. So obviously you're a busy clinical psychologist and fellow human, but your journey's taught you a lot up until now. And I'm sure often you find yourself sort of balancing, between life outside of the clinic and carrying someone else's suffering, because it's such a powerful engagement and encounter. How do you find that balance, and how do you carry the weight without collapsing?
It's tough. And I think we're all human and we all have our ups and downs. And so I'm a clinical psychologist for sure. I'm married. I have a husband who's also a physician who works a lot and is quite busy. We have 2 and 5-year-old boys. So there's a lot of moving pieces just of day-to-day life and keeping it all together. And I think the same message that we have for our patients in terms of having that robust care team, it applies to us too. Like, we also need our village. We also need our community, and we have to know our boundaries and limits and self-care. And that could look so differently for every single person. And so that might just mean, taking 3 seconds to ground in between patient appointments, or maybe picking up kids 10 minutes late so you could just take a breath and transition. So you go from one role to the other and you're not snappy and you're able to really be present with your family, and taking the time that you need to, maybe it's just an hour, and rather than an hour of just mindless scrolling, taking that hour for something more active in terms of relaxation and purpose that makes you feel like you, and that's important to yourself.
Probably translates into a lot more happiness. And that art of finding time is certainly probably one of the biggest challenges from the perspective of caregivers, or those who look after others, no matter in what capacity, professional or non. You mentioned this sort of Eureka moment when patients encounter your group, or I would say any group of individuals who've come together because of a shared goal of trying to help others. What do you think eases the suffering the most? Is it just knowing that there's a fresh vision? Does it translate into rather immediate effects on just alleviating chronic pain? Is there like a sudden, just from the encounter, like a 40% decrease? Or is it a sense of sort of empowerment? Now, maybe finally I can do this. Like, I've read about these books, but I've never had coaches, but now I've got this team coaching me. Like, what is it that pushes just that extra distance that allows people to sort of feel at ease, and feeling some of that suffering that's been there for so long start to move back?
It's a great question, and we should do that research study.
All right.
More work. I think, from my perspective, it might be hope.
Mm-hmm.
Hope that maybe something is in the future that will actually start to make a difference. Hope that there's a care team that is listening, that understands, and that knows what to do next. And so that hope can carry you really far. The exact metric and percentage about how much that alleviates and at what point, I'm not sure. I don't have the data and the evidence, and as a cool research study, maybe we'll include it in our questionnaire package. But the reality is that when you have hope, that translates to self-efficacy. So efficacy that you can make a difference in your life, efficacy that you could start to do things that might actually change your situation. And that is so incredibly powerful.
I can see the spillover being immense, and that once you get that trigger of hope, you suddenly feel a bit of empowerment when it comes to your other relationships and your other roles, be it parenting, be it partnering with your loved one, or even, your other responsibilities in everyday life.
For those of us who've only ever experienced acute pain, and maybe we're caring for someone in chronic pain, or we're just wanting a better understanding of what that feels like inside the body. I mean, maybe this is an overly simplistic way I've tried to imagine it, but stubbing your toe, and instead of that pain receding, in a minute or two, but it just stays and it's consistent. Is that close to what it's like? Can you give us an idea of what it's like for someone in chronic pain? Like, what's going on inside their body?
I think it's so variable. And so, what might feel like chronic pain in one person's body is going to feel totally different in somebody else. And that's part of the challenge in extrapolating and understanding and being able to have empathy for what that's like. And so, it might be just that sensation, but one of the common themes is it starts to spread. And so maybe it just starts in your toe is like a stabbing, aching, or whatever. And then it starts to spread up the foot into the calf and radiates into your hip. And the hip then starts to burn. And then because you have to change and adapt all of your activities, that starts to create a lot of dysfunction and disability and impairments in your everyday life. And then because it's not going away, and maybe you've been to 14 other practitioners and it's already been since 6 months, you start to get really down on yourself. So you start to think, is this forever? Is this going to get better at any time? Is this always going to be my life? What does this mean for me? And then maybe you start to have a lot of anxiety in terms of, if I sit this way, is this going to make it worse? What does this mean? Can I go with my kids to a playground? And if I can't, what are they going to think of me? And then you start to see the whole trickle effect of the fear, the low mood, the avoidance, and everything that comes from something that maybe it just starts in terms of pain in your toe, but then it starts to spread to throughout your body, different characteristics, taking over your mental health, all of your life roles and functioning. And how do you get out of this, and where do you intervene?
Wow. I just have one more follow-up to that. And this may be a moment that you don't get to because people don't come to you into the later stages of their chronic pain career, as Dr. Tripp calls it. But there must be a moment where people look at their lives and all of these feelings, and this is just taking over everything. And they must have this moment where, like, holy fuck, like, this is my life. Mm-hmm. Like, this is my whole life is going to be about this now. When does that sort of occur? And then how do you, as a clinician, sort of get them out of that thinking in that space?
That's a great question. And I think it can hit people at different points for different reasons. And, we have to understand that the chronic pain patient doesn't come in just from the point of their injury. They exist and have existed for all of their previous life experiences. And so that will impact, what happens in terms of their presentation and how they're coping with things, earlier relationships, what's going on in their life, their psychosocial stressors, early childhood stuff and traumas. And so when that person comes to see you, you have to acknowledge that whole history, their development, and everything else that's going on. And when you start to see them as that whole person, that's when you can really start to make a change in their life and help them take a step forward. And chronic pain is and should never be treated individually. Like, this is a complex condition that requires an interdisciplinary team approach. And that's exactly why, because not one single person, just like, has been mentioned before, can take all of it away. Maybe it's 7% from here and 10% from there and 20% from here. And when you add up all those pieces, there's a 60% improvement. And that's why I'm a huge proponent that, in order to treat these complex chronic abdominal and pelvic pain conditions, we really do need community and a team approach.
That's a huge acknowledgement. And at the same time, what's the hardest scenario that you've come across when you're actually trying to help people with chronic pain, where you put all this out of on the table, but it's not working? What do patients need to bring to the table also, or be prepared to hear if they're going to benefit the most from these interventions? Because there's a two-way engagement, and there has to be buy-in. So can you share with us a little bit some of the challenges that you come across where you get a sense that, this may not work?
Mm-hmm. There's so many different factors that go into somebody's readiness and ability to start to engage in treatment. And so, when we talk about readiness for change, we have pre-contemplation, contemplation, action, and maintenance. And a lot of the times, the patients that we see that are not engaging, that are treatment resistant, all of those sorts of factors, they're stuck in the pre-contemplation phase. And what that means is that they are dead set. This is a medical condition. There is a diagnosis that has not been found yet. There's going to be one treatment, one medication, one surgery that's going to take it all away and fix the problem. And so our job is to help them understand that neurobiology of their nervous system and pain and how it works and why it works, because then they might start to inch towards more the contemplation action stages of readiness for change, and they might be more able to adapt these kinds of understandings of what their experiences are. And so that's one explanation. I think, there's so many systems issues that are really challenging. If somebody is financially unstable, if they're in and out of jobs, if they're having trouble, securing housing, if they're in relationships that are unsafe, physically, sexually, mentally, emotionally, how are we going to get them to start to adopt this interdisciplinary approach when the reality is that their nervous system's unsafe because their environment is actually unsafe? And so some of the first proponents and things that you can do as part of trauma treatment is actually help that person become more stable and safe in their environment and their relationships in their life. And once they're feeling more safe, they're much more likely to be ready to make changes and adopt this interdisciplinary approach.
That's a huge message, I think, to practitioners everywhere and to patients and their advocates, in that while access to these more comprehensive programs may not be accessible, taking some of the first high-stakes steps towards remedying what's keeping the patient in sort of overdrive in terms of stress and anxiety because of those same examples like you mentioned, would be huge. And that's something any caregiver can advocate for or refer to, whether it's help with substance use disorders or more dedicated focal groups for abuse recovery or other types of activities. So I think that's within reach of all of us, even though model systems like yours are not on every street corner. There are things we can do to get the ball rolling, to be able to prepare someone for perhaps eventually a more, not only more meaningful, but a conversation that has a better likelihood of transitioning from, an invisible chronic pain sufferer to someone who feels like they're back in charge of their life and with a new identity that they can actually shape the direction. Can you share with us a before and after story of a scenario that really stands out to you where someone's relationship with their pain shifted so much that they just had this huge turnaround? Is there anything that sticks out for you?
There's so many snippets of different, interactions and things that I can share. Maybe I can walk you through what it was like for, one patient that came through our Endo 360 program, longstanding issues with multiple chronic pain issues. So endometriosis, fibromyalgia, gastrointestinal symptoms. We get a lot of rumination and the weird and wonderful, where there may not be a definitive diagnosis or treatment that can help. And if you look at that person's history, longstanding history of things like depression, anxiety, and then as you start to assess and go into their history, of course, a history of something like a sexual assault that may have happened earlier on in their life. And then they start getting into all these medical appointments, where maybe they felt invalidated or dismissed, medical exams that kind of dissociate and go numb. They're not really paying attention. So it's really hard for them to speak up in all of these appointments. And then, they finally get in with, either a gastroenterologist or a gynecologist that hears them, that sees them, that starts to, put all the pieces together and diagnoses them with endometriosis, and they're able to get some treatment, potentially surgery, and then they get forwarded to our Endo 360 program. And so within our consultation and assessment, it's often the first time that they've been surrounded by a team altogether where they feel truly heard and seen, and they don't feel helpless about their situation anymore. And we start to give some recommendations about different things that might be helpful for them. Ultimately, coming to our group program might be a good step. And so throughout the weeks, we talk about everything from, that neurobiology and the science of pain and endo to how to cope and deal with flare-ups, to pain, sex, intimacy, and, how to deal with the nervous system and trauma. And so week by week, you start to see all these changes in terms of putting the pieces together and starting to connect with other women, within our group for the first time in a very proactive and helpful way. And by the end of the program, they're not so reliant on a lot of their medical treatments, and they're not hung up on, going to all these appointments and, seeking other third, fourth, fifth opinions, possibly going to the US for all these things. And they start to have to reevaluate, who am I? Because for the past 10 years and most of their lives, they've been this chronic pain patient that's totally been present in every interaction in terms of their school, their dating, their future, their career. And then they have to truly evaluate what's next for them. And so I think being able to have a patient, come all that way and then start to work with them individually and help them develop this sense of identity and talk about, existentially what it means to be them as a person and what they value and what's important, and help them get into finding careers and relationships that are supportive and safe and help them thrive. It's incredibly a unique experience, and I wouldn't change anything about it.
It's as though you're going from an imprisoned state to a state of freedom, and it's like you can't quite fathom how you're going to function in that new state of freedom. And of course, it still takes baby steps as you engage with your new environment and your new identity. That's an incredible story.
And to follow up on that, I really want to... You just said something that was so important that I wanted to point out. It's the fact that sometimes feeling safe and out of pain can be as distressing and uncomfortable as the contrast. And so just because the patient doesn't have symptoms and, you feel like, great, my job is done, like I helped them, they're no longer experiencing, symptoms or issues anymore, they still might have distress. And so, having that team around them and referral sources to help the patient with next steps can be as important as well.
Well, there's a very famous movie, which I'm sure you know, The Shawshank Redemption, where one's identity upon release became suddenly a traumatic experience because you had no idea how to function outside once you were used to functioning within the cone of that sphere of identity for so many decades beforehand. And the analogy fits quite well in being imprisoned by that identity of chronic pain and how it completely takes over your ways of living day to day. And then suddenly you need to sort of rebuild with exuberance, but at the same time, distressing and overwhelming in a way as well. If we were to shift to back to caregivers and loved ones who play important roles in patients suffering with chronic pain, can you leave us with a couple of sort of real practical tips how those individuals can just show up and be there for people they care for with chronic pain and suffering?
I think It's the same as with any kind of relationship. Just because you don't understand, or you may not even be able to empathize or get what that experience is like, a lot of time people just want you to be present with them. We have this natural instinct to fix, to cure, to solve. And a lot of the times with these kinds of conditions and these complex symptoms and presentations, it may not be possible. And so if you have a chronic pain patient that you're caring for, both, as a clinician or personally in your life, sometimes the best thing you can do is just be present with that person and listen and help them feel heard and validated, because that can be so much power in terms of their next steps and what they do.
As you said, not take on the burden to fix, because there's no immediate fix. And as someone standing by another, we can't assume that we somehow have that power to take one step and fix it. The same rules apply as we shape our vision as individuals engaged with people we love or care about, or professionally taken care of. So if someone listening today in the audience, and we've got a broad listenership, we're very grateful for that. But if they remember only one thing about chronic pain, what would you want that to be?
That's a big one. I think
we try.
The big questions over here. If there's one thing to remember about chronic pain,
it's a building block to carry their own learning forward. Because I think some listeners today are going to say, I need to read more. I need to research it. I need to think about this a little bit more. So what's like one catalyst takeaway from today that's really hopefully could turn some people in the right direction?
I think it's to not feel overwhelmed, shut down, walk away, refer on. I think we have a lot of ability, like we just talked about, to be present with both people personally in our life and professionally as caregivers. And there's so much that you can offer, from trying to understand how 30 different symptoms or conditions may be tied to one thing. And so if we can help patients understand that central sensitization or nervous system approach and help guide them to potentially care teams or resources and referrals, that can be so incredibly helpful. And not to feel like you yourself as the individual has to fix the problem.
Are there any good online resources to identify groups who provide services across, the province of Ontario where we are, or even across Canada or the US? Are there like repositories or sites where they've got regional resources? Because obviously there's spread by word of mouth, but people need to at least know where they can turn. And we all know that funding can be a challenge as well, because a lot of this is not funded through Medicaid or Medicare or other things, yet it's amazing how valuable a tool this could be in changing people's overall perception of their own health, yet it's potentially inaccessible, hence the need for as many people to know about it as possible in the different domains of caregiving. But are there good resources for the population to turn to find out what's available for different conditions?
Absolutely. Most academic tertiary hospitals will have a pain clinic, and those pain clinics are super rich and resourceful in terms of the types of information that they can recommend. And so a referral to the pain clinic can always be helpful, and it may not be to, for interventions or to see an anesthesiologist or a pain medicine doc. It might just be for some of their programming for pain management and then education. There's some really neat resources online. I know the TAPME group has something called PainU, which has a bunch of different models that really gets into that pain neuroscience education. It's for the lay person. They've done it really nicely and well, so patients can check out PainU on TAPME. And then there's online pain management groups. I think they're done by the province. I forget their exact name, but they're 8-week pain management groups. And, sometimes they're not all that relatable or adaptable, but the information is solid and you can definitely extrapolate and apply to whatever condition that you're going through. And sometimes that's just enough to give you a head start to start to get into or realize where your next steps might be and what holes you might be getting stuck in.
Well, we'll try and include some of those resources with the episode links, etc., including your own links to your Instagram and to Endo360. We've certainly been on an interesting journey today because we've spoken about the patient and we've spoken about the individuals, caring about them and the impact, but also what they can do to help patients and the people they love on their journeys and dealing with chronic pain, and hopefully they're reawakening towards a new path towards living more wholesomely themselves, while acknowledging that some element of chronic pain may still be present, but that doesn't need to take over their identity. Some patients have been living with chronic pain for so long that that they're not sure if they can just keep going the way they are. What would be your parting message to that group who are listening, who are just at that point where they don't know where to turn or they don't know if they can keep going?
I think that's the point that you might want to check out some resources for mental health support. We have the Ontario Structured Psychotherapy Program that offers some free sessions. Your local hospital or helplines might be able to offer you some counseling. And the reality is that there is so much research and support and evidence that when you start to treat the underlying mental health conditions, so things like anxiety, depression, and trauma, it takes a huge weight off of the pain. And they work so bidirectionally in the sense that the more pain you have, the more mental health issues that come up, and the more mental health issues that you might have cause more pain just because of that nervous system approach. And so it's not about taking the pain away. It's about learning to develop a different relationship with it so it doesn't impact you or distress you in the same way that it is today. And there's lots of resources that can help an individual.
So block that feed forward loop that just keeps feeding it. I was amazed at that notion of how, you stub your toe and have acute pain, and sometime down the line, you may actually have hip pain that's burning as a result of the original toe stub. Is there a type of patient that's more prone to evolving that way from the beginning? Like, are there any biomarkers or psychological markers or tests that predict whether, or is it purely random?
No, there's a huge field of psychoneuroimmunology, and there's a lot of really cool studies that are going on looking at all of these markers and predictors of, how acute turns to chronic pain and so on. What I see clinically definitely is, if your nervous system is already on a state of high alert, hypervigilance, you're much more likely to have a widespread pain response. And that's evolutionary and adaptive, because if you're in this state where you're chronically running from that Velociraptor or that bear, it makes a lot of sense that if your if your toe gets stubbed, your whole body has to be hypervigilant to make sure that you can keep running because you're constantly in danger. And so there definitely is a lot of different predisposing factors that might contribute to somebody's nervous system being on that high alert, whether that's psychosocial stressors, whether that's relationship, whether that's abuse or trauma or mental health or, lots of different factors. But essentially, it usually stems from the fact that there's something that's contributing. That could even be viral, or other conditions that are contributing as well. But when that nervous system is already in a state of hypervigilance, there's much more likely to be a response that acute turns to chronic pain.
I wanted to thank you for joining us today. You've brought so much insight to the discussion. But as I step back and listen, and then I think about all the resources that are out there today that we all as individuals could potentially tap into, ones that are validated, and I'm starting to see recurring themes. And I I really wonder whether or not, it should be incorporated into either high school or college curriculum. But I know it's been done at the Harvard Business School. It's one of the most popular courses. It's called the Happiness course. If I remember correctly, I remember hearing even the Department of Psychology at Queen's, I think, has a Happiness 101 type of introduction type course that's being offered. But maybe we all need to learn how to check in at certain key milestones in our development, whether it's the end of high school or the end of college or university, where we just sort of take an inventory, say, maybe I got to let a couple of things go to get me ready for what's in store. And that could have such broad sweeping effects on people's futures, and would be valuable learning, as valuable as probably a lot of other stuff we learn in those academic pursuits, which may not be as valuable in life, but it's certainly starting to resonate.
Say.
Pardon
me? If not more, I think, I talk a lot about this, the fact that there are basic components of cognitive behavioral therapy, and that's the kind of therapy that I do, that if we just understood how our thoughts and our feelings and our bodies actually all work together, we would be so much better off. Like, why aren't they teaching this in kindergarten, in elementary school, in high school, in college courses, just like you're talking about? We would be able to just thrive.
And adapted for that age and continuum. Yeah, I agree.
Totally.
I think it could empower our world so much more. And it would certainly be a nice oppositional force to, the dopamine-driven, depersonalizing effects of all the rapid wants and perceived needs out there, which don't automatically result in a sense of fulfillment or happiness. I would hope that you might forward us a couple of good book recommendations that we'll include with the notes of this episode, and want to wish you well. Thank you for being here, and we look forward to hearing an update on your successes in the future, and you'll always be welcome in our podcast family.
Well, thank you so much. And it's been great for you to have me, and look forward to being back.
Thanks, Laura. That wraps up this week's episode. We're so glad you joined us. For those of you who are new, we hope that you learned something from us and look forward to visiting with you again. Until next week, I'm Dr. Mark. See you next time. Before we wrap up, I wanted to remind you of something important. The conversations you hear on this podcast are here to inform, to support, to spark reflection. They're not a substitute for professional medical advice, care, therapy, or crisis services. Listening to this podcast does not create a doctor-patient or caregiver-client relationship between us. If you're facing a medical concern, health challenge, a mental health challenge, or a caregiving situation that needs guidance, I encourage you to reach out to a qualified professional who knows your story. If you're ever in crisis, please don't wait. Call your local emergency number or recognized crisis hotline right away. You deserve real-time help and support. The views you hear on this show, whether from me or my guests, are our own. They don't necessarily reflect any organizations we work with or are part of or have worked with or been part of in the past. This podcast is an independent production. It's not tied to any hospital, university, or healthcare system. Thank you for being here, for listening, and most of all, for taking the time to care for yourself while you continue to care for others. I look forward to hearing from you.